All right, let's get started. Deep inside every chest, there's an engine, an incredibly complex, violent, clockwork marvel of valves and pistons, all powered by a single spark of life. Now, as a mechanic of the human body, your job is to master this machine. You've got to understand its rhythms, its whispers, and its screams before the whole thing just grinds to a catastrophic halt. Your shift has started. Let's get to work.
Look at this thing. It's not just a heart, it's a high-stakes mechanism. And the ECG, well, that's its diagnostic language. It's a cryptic printout of every single gear turn and pressure spike. Our job right now is to translate that code, to see the malfunction before it becomes fatal. Your patient's life literally depends on you reading these signals and reading them fast.
So, before you can even think about fixing what's broken, you have to know the machine's design inside and out. To spot a glitch, you first need to know the rhythm of a perfectly running engine. This is our baseline. This is the blueprint for normal operation.
What you're looking at here is the perfect firing sequence. Every single normal beat follows this exact signature. See that first little bump, the P wave? That's the spark. That's the atrial ignition as they depolarize. Then, boom, the massive QRS complex. That's the main event, The powerful synchronized contraction of the ventricles. That's the power stroke that sends blood out to the entire system. And finally, the T wave. That's just the reset, the electrical repolarization, getting those pistons ready to fire all over again. Ignition, power stroke, reset. Simple as that.
So, how does that spark actually travel? Well, it all starts at the top with the SA node. Think of it as the machine's master clock, firing away at 60 to 100 beats per minute. From there, the signal hits the AV node. Now, this is a crucial central relay because it intentionally slows the impulse down, just for a fraction of a second, just long enough for the ventricles to fill up with blood. Then that signal shoots down the bundle of His. It splits into the bundle branches, and finally, it energizes the entire ventricular muscle through the Purkinje fibers, the whole power grid. It's this precise, elegant pathway that keeps the machine humming along perfectly.
But what happens when the master clock itself starts to malfunction? When it runs way too slow or revs dangerously high? These are what we call rate faults. They're the first and honestly the most common category of engine trouble. So let's diagnose our first set of malfunctions.
And here's our first glitch, sinus bradycardia. Just look at this strip. The rhythm is regular, right? The P, Q, RS, and T waves are all there. They're all perfectly formed. But the master clock is, well, it's sluggish. The rate is below 60 beats per minute. The engine is idling way too low, and that means it might not be generating enough power to keep the whole system running.
Okay, so here's the crucial question in triage. The first thing you have to ask, is the patient symptomatic? Are they dizzy? Are they passing out? Is their blood pressure in the tank? If the answer is yes, the machine is failing, and we need to intervene now. The go-to chemical accelerant is atropine. If that doesn't work, we hook them up to a transcutaneous pacer to physically force the engine up to speed. But, and this is a huge exam alert, if your patient is a marathon runner with a heart rate of 50 and they feel totally fine, you do nothing. Asymptomatic bradycardia can actually be a sign of a highly efficient engine. Never ever fix what isn't broken.
Now let's look at the exact opposite problem, sinus tachycardia. Here, the master clock is firing over 100 times a minute. The engine is just screaming, it's redlining, and no engine can sustain that kind of stress forever. It's burning way too much fuel, it's putting too much strain on all the components. Our job isn't just to slow it down, it's to figure out why it's running so hot in the first place.
Tachycardia is a symptom, it's not the disease. So you have to be a detective. Is the patient in pain? Do they have a fever? Are they hypoxic? Giving a beta blocker to a tachycardic patient who has a raging fever, that's like cutting the wire to the fire alarm while the building is burning down around you. You have to find and treat the cause. And here's a critical exam tip for you. In a patient who's had a heart attack, persistent tachycardia is a really ominous sign. It could be telling you that the pump is failing and heading straight for cardiogenic shock.
Okay, now we're moving deeper into the machine. The master clock is firing perfectly fine, but the signal is getting lost or delayed on its way to the ventricles. This is a communication failure at that central relay, the AV node. These are the heart blocks.
And this just perfectly illustrates this escalating failure. In a first-degree block, every single signal gets through, it's just slow. The PR interval is prolonged.
Then you get to second-degree type 1, where the delay gets longer and longer and longer until a beat is dropped entirely. You can usually see it coming, but in type 2, beats are dropped randomly, without any warning at all. This is way more dangerous. And finally, you have third-degree, or complete heart block, where the communication line is totally severed. The atria and the ventricles are just doing their own thing.
I mean, just look at this chaos. The P waves, the atrial ignitions, they're just marching along at their own regular pace. But the QRS complexes, the ventricular power strokes, are just plodding along at this dangerously slow escape rhythm. There is absolutely no relationship between them. This is a complete system failure. It's a mechanical divorce that requires immediate, and I mean immediate, intervention.
For these high-degree blocks, there is no time to waste. The patient is going to have severe symptoms because the pump is barely working. The fix is external pacing, right now. We have to take over control of the ventricles. And this is your #1 exam alert for blocks. While atropine works up on the SA node, the problem here is below that point. So it's not going to fix a type 2 or a third-degree block. The definitive answer on your exam is, and always will be, pacing.
We are now entering the most dangerous part of the engine room. The problems are no longer with the clock or the relays. Now the malfunction is in the main pumps themselves, the ventricles. These are the rhythms that kill, and they kill in minutes.
This is ventricular tachycardia. Some rogue electrical focus in the ventricles has completely hijacked the system, and it's firing at a blistering pace. Look at those wide, bizarre QRS complexes. This is not a sustainable rhythm. The ventricles are beating way too fast to fill properly, and cardiac output is plummeting. The machine is literally shaking itself apart.
When you see this rhythm on the monitor, your first action isn't to grab a drug. It's to put your hand on the patient. Do they have a pulse? That one question determines your entire path. If there's a pulse and they're stable, okay, we use antiarrhythmics like amiodarone. If they have a pulse but they're unstable, hypotensive, altered, we deliver a synchronized shock. But if there is no pulse, this is cardiac arrest. We start CPR and deliver a high-energy, unsynchronized shock. That's defibrillation. You absolutely have to know the difference for your exam. It's the difference between life and death.
And then there's this, ventricular fibrillation. This isn't a rhythm. This is electrical anarchy. The power grid is completely short-circuited into just a chaotic, useless mess. There's no coordination, there's no QRS, there's no power stroke. The heart is just quivering. There is zero cardiac output. This is the death rattle of the machine.
For VFib, the only fix is high-quality CPR and immediate defibrillation to try and reset the entire chaotic system. But what about asystole, the flat line? Here it is, the most missed exam question in all of ACLS. You cannot shock a flat line. There's no electrical activity to reset. Shocking asystole does absolutely nothing. The only treatment is excellent CPR and drugs like epinephrine to try and kickstart some kind of activity. Do not forget that.
Okay, you've seen the blueprints and you've seen the catastrophic failures. Now it's time for the final test. The machine will often send you subtle, confusing signals. A master mechanic can tell the difference.
So let's look at two strips that, at first glance, appear very, very similar. Both of them originate from the AV junction, which is the backup pacemaker. But one of them is a stable, reliable backup system, while the other hints at an irritable, unstable engine. Can you spot the critical difference?
On the left, you've got a standard junctional rhythm, just ticking along at its normal intrinsic rate of 40 to 60. Yeah, it's slow, but it's the expected backup pace. Now, on the right, you have an accelerated junctional rhythm. The shape, the morphology is the same, but look at the rate. It's faster, between 60 and 100. This isn't a backup anymore. This is an irritable focus that's become overexcited, often from something like digoxin toxicity. The only difference is the rate, but the clinical implication is absolutely huge.
Every good mechanic has a toolkit. This is yours. Let's break it down. Sodium channel blockers like lidocaine, they work right on the ventricular cells, slowing down electrical conduction, which is why they widen the QRS. Beta blockers, like metoprolol, they act on the SA node, basically putting a governor on the engine to slow that master clock. Amiodarone, which is a potassium channel blocker, it works by delaying repolarization. That prolongs the entire reset phase, the QT interval. And finally, calcium channel blockers like diltiazem, they slow the signal as it passes through the AV node, which in turn slows the heart rate and lengthens the PR interval. You have to know your tools, and you have to know their effects.
I want you to remember this. The heart is a relentless machine. It will not wait for you to feel confident. It's going to fail on its own terms, often without any warning.
Your job is to be vigilant. Your job is to listen to the machine because it's talking to you right now.